Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. This is Josh Sharfstein. Today, a new and promising way for emergency medical services to respond to an opioid overdose right after it has happened. I speak with Dr. Gerard Carroll, the division head of EMS and disaster medicine and an emergency department physician at Cooper University Healthcare in Camden, New Jersey. Let's listen. Dr. Carroll, welcome to Public Health on Call. Very excited to talk to you about some very interesting work you've done in responding to overdose, which is still an enormous national crisis. Could you start by talking a little bit about your background, the kind of doctor that you are?
Sure. So thank you for having me on the podcast. My name is Gerard Carroll. I'm an emergency physician, emergency medical services physician, and an addiction physician. So I'm kind of a little bit of a doctor of all trades, if you will. I got into medicine 30 years ago as an EMS provider, first emergency medical technician, then as a paramedic for 10 years in New York City, before going back to medical school up in Dartmouth, training over at Temple in emergency medicine. And then I've been at Cooper practicing both emergency medicine, emergency medical services, and more recently now addiction medicine as part of both of those specialties.
I imagine one reason you might have become interested in addiction medicine is that emergency medical services have to respond to overdoses quite a lot.
Absolutely. And what became something that was just a small part of our EMS practice has now grown into, as the opioid crisis has hit the entire nation, it's hit EMS on the forefront of that, and emergency medicine as well.
So let's talk about the typical way an ambulance responds to an overdose, and then we'll get into some of the innovations that you've been working on.
Sure. So I think we'll focus on opioid overdoses because obviously it's a broad category. And this is something that EMS has been doing for long before I was in EMS medicine. Somebody who is using opiates either for pain recreationally or more commonly once they're addicted will get too much. And at high doses, opiates stops the respiratory centers in the brain and people stop breathing, and that can cause a cardiac arrest and death. EMS is someone, as soon as that happens, and the big thing right there is the patient is not breathing. And so the focus is on ventilating that patient artificially with a bag valve mask and stabilizing that situation. Secondarily, we have an antidote for opiates called naloxone or Narcan, and that's given. And between those two interventions, the majority of patients on strict opiate overdoses, if we get there in time, are resuscitated back to their normal selves. That's kind of the basic things and how they stood for a long time.
But before we go further, I just want to say, okay, so you've got someone who has had an opioid overdose. You have helped them with their airway. You have then given them some ventilation and reversed the overdose with naloxone. Then what happens to the person in the usual way of doing business?
Right. So the good news is the patient begins breathing again. The patient wakes up, and that was the goal. The unintended or iatrogenic side effect of that is that you precipitate opiate withdrawal. Once you become addicted to opiates, there's a baseline level of opiates that patients who are addicted with that disorder need just to function in the world. That opiate withdrawal is both physically, but also even more critically, mentally terrifying for addicts. And so quickly in front of EMS, as the naloxone continues to displace opiates beyond just what it took to make people breathe again, those patients will get sick. This will be manifested by sweating, vomiting, diarrhea, number of different kinds of symptoms, very distressing to the patient, and something that we in EMS have never been able to do much about, except hope that it would wear off later.
And at that moment, you might say, all right, why don't you get in the ambulance? We'll take you to the hospital, but the person may not be so interested in going at that point.
Right. That was one of the fascinating things that's happened. That's a more recent change. So traditionally, if you overdose, most places, and I don't want to overgeneralize, most patients would overdose and they would go to the hospital. And it was variable what could be provided for them at the hospital, but that kind of was the normal pathway. In the last 5 years, certainly in my EMS service, we were having 3 to 5% of those patients refuse transport after resuscitation. And now we're approaching 50% in some cohorts. And so that's half of our patients who are resuscitated this way who don't access any other healthcare provider.
And what does that look like when you're out in the field? Why do people say they don't want to go to the hospital?
Right. So, I mean, a little of this is inference. A lot of patients don't share a lot. They're in distress. They're not happy. I mean, maybe just to set the stage a little bit, patients who overdose, especially the sicker patients with opiate use disorder, are often in a publicly exposed place. They may have been robbed prior to someone actually calling 911 for them. They wake up to a crowd. They feel terrible. Not only do they feel terrible, but they're feeling more and more terrible as the withdrawal continues to mount, and their medication is continuing to work in their system to make them sicker. My guess is, and I'm pretty sure I'm right, is that they've interacted with the healthcare system before, and it wasn't a great experience. And so that combination and the fact that there hasn't been ready treatment for their withdrawal leads to them going to try and use more drugs and get away from the situation that's already uncomfortable.
So in a sense, you've saved their life, but the way that you've saved their life might put them at risk for overdosing again.
That's one of our biggest fears, is that you're in opiate withdrawal. And the interesting thing about naloxone is that it only has a half-life, which means it lasts in the body only about 90 minutes. And those times are variable in different studies, but that's around the time frame. So while we don't see tons of this, there's this theoretical chance that you would go use more opiates in that 90-minute window, that medicine would wear off and you would still have some of the opiates you had before, leading to another overdose.
So you want to try something different. Tell us what that is.
Yeah, so because of our EMS service began seeing so much more of this in the last few years, to the point where I was worried about compassion fatigue and burnout, and my providers just can't resuscitate people to no strong end and then eventually see them in cardiac arrest. That kind of compassion fatigue is just natural human defense mechanism. And the fact that we weren't meeting the needs of this population, we started thinking about what we could do for these patients. What was the next step? In the outpatient arena, and now commonly in the emergency department, we're starting people on buprenorphine, which is a partial agonist, high affinity opioid, which is a long-term treatment for opiate use disorder. But it had never really been used in the acute overdose setting. And we kind of postulated that maybe that would stop some of these side effects and get people the next step they needed in their treatment.
Let's just talk about buprenorphine for a second. It might actually treat some of the withdrawal symptoms, right? Those horrible symptoms and feelings that you would describe as getting worse for people. Buprenorphine may take away withdrawal. Is that one reason you're thinking about it?
Correct. The way I like to think of buprenorphine is, if you think of a light switch and you consider that light switch one of the opiate receptor in your brain, if you take any other opiate you've ever heard of, oxycodone, Percocet, hydrocodone, morphine, Dilaudid, all of the names you've heard in the press, and fentanyl and heroin, that switch continues to be turned on all the way until you stop breathing when you take it. Buprenorphine, on the other hand, is we call a partial agonist. And so it can only turn that light switch on halfway, which gives it a fairly decent safety profile for patients with opiate use disorder. I don't know if that's getting too technical into the pharmacology, but that idea that it's very difficult, not impossible, because it's an opiate, for it to cause respiratory depression. But because it's an opiate, it can bind to those receptors that we've knocked the drugs off with the naloxone. And so therefore, we can alleviate those withdrawal symptoms when given the right way.
And you also have the benefit, as you said before, that buprenorphine can be a long-term treatment. So it could actually be the first step of people taking a medication that treats the addiction that they have.
Correct. And that was, doing one without the other seemed to be questionable. We wanted to make people feel better, but more importantly, we wanted to get people back into their lives. Patients with opiate use disorder have 6 times the mortality of the general population. And if you can get people onto long-term buprenorphine, you can reduce that by 2/3. So it's a significantly patient-centered outcome for a very affordable medication.
What I hear you saying is, look, we could take them to the emergency department and they would get started on buprenorphine there, particularly at your hospital. But since half the people aren't going, is there a way to actually start buprenorphine right there, right after the person has overdosed?
Yes. And in fact, I think because this is going to be different in different parts of the country, right, how many patients do and do not go with EMS to the hospital. But what's very common in much of the country, especially right now, is that those patients, even when you go to the emergency department, the care is not always provided there, not because myself as an emergency physician or my colleagues don't want to give it to you, but because there are 30 people in the waiting room and waiting times are in excess of 10 hours some places and rarely less than 2 or 3. This population, even when they go to the hospital, often never sees a physician because they can't wait in their withdrawal that long. But that 50% that I can prove is that problem, we wanted to do something different. And so we talked about starting buprenorphine in the field with our EMS service.
So you were one of the investigators that did this. Tell us what happened.
Yeah. So over a 4-year period, we introduced buprenorphine in a stepwise, staggered way along all of our ambulances in Camden, New Jersey. We trained all our paramedics. We did an interesting kind of setup because part of buprenorphine therapy is the medication, but part of treating patients, and this is also evidence-based, is the engagement process, right? And the empathy process, which I know gets onto the touchy-feely side of medicine, but it's critical because we were asking patients to agree to something. This is no longer the same level of emergency. Patients now have their capacity back. So we kind of spurred a training program, added buprenorphine to the EMS armamentarium. We got support from the state to do this, which was critical. And we deployed it over that period. And the results were pretty amazing. Over that period of time, patients who took the buprenorphine, which was a small percentage, probably 1 in 10 of the patients offered. So it's still a pretty new treatment and still very difficult to convince patients until it gets more traction, which is one of the reasons I'm excited to talk about it here. But patients who took it, we measure withdrawal with an opiate withdrawal scale called the COWS score. And our average score went from about 11 to about 4. And so that's an incredibly patient-centered change in how they're feeling, right? And some numbers went from 33 to 2. So really, really big changes.
Just so I understand, someone is overdosed. The ambulance gets there, the EMTs get out, and they will give naloxone first to reverse the overdose. And then if the person agrees, you would give them a dose of buprenorphine right there. And what you're finding is that their withdrawal actually goes down quite a lot.
Correct. But maybe I can give like an example. So it's the afternoon on the city street. EMS rolls up to a poor guy laying out right on the sidewalk. His pants are half down. There's needle and drug paraphernalia around. There's some other things that are kind of gross nearby. And EMS, the fire department, the police department, bystanders potentially are all there. He gets resuscitated. And we all know what's been going on, but he has not been breathing. It's certainly not been part of that equation because he was so sedated on the medication he overdosed on. And then he wakes up suddenly. He has vomit and secretions on his face. He has a nasal airway in his nose. And there's all these people, some with guns, all surrounding him. So it's a really terrifying moment for that patient as they regain capacity in the world. In that moment, what we changed from that horrible experience is we needed to stop that terrifying moment, get that patient comfortable, so we could then pivot to a whole new conversation on a patient who, let's be honest, I don't imagine having a conversation with anyone if I were in that situation. And so from there, you have to have a conversation with the patient about their evolving situation, the withdrawal that they're about to hit, the fact that they were probably robbed, the embarrassment and just shame of being in that situation, and then talk about the medication. And so what our paramedics will do is they will do a lot of patient-centered education, discussion about where the clinics are. Getting into clinic for opiate users is very difficult. There's still lots of trouble with access across the country. And this program provides direct entry within 24 hours of weekdays and 48 hours on weekends. Then they'll give them 2 of these sublingual films of buprenorphine. And then they'll just stay with the patient for a short time to see if they're getting better or worse. And so the amazing thing was this patient in this example, his COWS score, and I was one of the first patients I did, so I always remember him, was 24, which is ungodly miserable withdrawal. We watched him, we gave him the medication. About 15 minutes later on scene, after a second dose of buprenorphine, his COWS was 2. And honestly, it was subjectively 0. And he attended our appointment. He didn't actually come on time 2 days later. And at 30 days, he was still in recovery. And so you never want to do science with one patient, but that's kind of the magic of what we were trying to do.
So it's a very helpful story to understand. And I think what you're saying is, first of all, it makes the person feel better right there. But does it also help them actually get into treatment later?
Yeah, so that's an important point to touch on. One of the biggest challenges of taking long-term buprenorphine treatment is that, like I talked about, it turns the light switch only on halfway. It also is a strong opiate binder, and to the point where it can also cause withdrawal when you start it. And so one of the hardest things for patients is nobody wants to go through withdrawal. And I don't mean that like nobody wants to go to eat their Brussels sprouts. Like this is like a primal, miserable experience. Getting people to switch from one medication to the other can be a super big challenge in the outpatient arrangement. It just can take weeks. We have people who just don't make it for months on end. In this moment, someone, because they overdosed, because they got Narcan, and now we've given them this large dose of buprenorphine, we've solved that induction that sometimes takes admission to rehab, hospital admission, and that patient is on that medication. Now, whether or not they can continue it and follow up is still not perfect. And we certainly don't get 100% of them to move forward, but we've kind of crossed that whole barrier in a very novel way, in my opinion, that's not available in most places, certainly not in the clinics we work in.
And when I read the paper, what I saw was that you compared the patients who were able to start buprenorphine with patients who were not able to be offered buprenorphine because it wasn't on those ambulances. And patients were much more likely to be in treatment if they actually got buprenorphine from the ambulance.
No, and that's correct. And that increase in engagement was amazing, right? So I never like to do a ton of stats, but the odds of engagement in opiate use disorder treatment within 30 days of that encounter was giving you an odds ratio of 5.6.
So 5 times the odds of being in treatment 30 days later.
Yes, that's an impressive number. And it's still a small number. And I never like to present data as something as this is the cure for the opioid crisis. We can all move on to something else. But I do think this is an important tool for a subset of the sickest patients and a very cheap intervention.
So what's next for this approach? Are other places beginning to give buprenorphine to people who have overdosed?
Yes, one of the exciting things is our program is being picked up in other EMS services across the country, places like in California, Pittsburgh, and Pennsylvania, the entire state of Delaware, and parts of Canada are all trying this program out. So not only can we help more people, but we can confirm that the early data we have here really is the promising thing we think it is. And the hope to someday move into the point where not only can we help these people in the field, but perhaps we can dose them for the first few days afterward to really kind of clinch that induction onto the medication long term.
Got it. Well, Dr. Carroll, thank you so much for joining us on Public Health On Call.
Awesome. Thanks.
Public Health On Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.